All right. Thanks, Jessie. So I'm going to start, and I'm going to go pretty quickly through our presentation today, which is really about neonatal abstinence syndrome and some of the looks and feels of some developmental things that might happen for kids with exposure. I just want to iterate, and I'll continue to reiterate this throughout this presentation, that all of these are things that could be present, and none of them are things that will be present necessarily. More than any other, I would say, sort of interest case example, I think neonatal abstinence syndrome is really unpredictable, and that it comes out in lots of different ways or not with children who are exposed. So just keep in mind as we're talking about some of these things that what I want you to know most about it is just that it is really variable, the ways in which NAS and others can affect development, and that might look different for different children. So keeping that in mind. And I also want to acknowledge that as I look around the room, I see lots of colleagues who've worked really closely with me with children and families, and that I see a lot of expertise in the room, a lot of years of experience here. So I'm also going to breeze right through our slides here because I'm interested in having time for questions and hoping that my colleagues will jump right in. And finally, part of this is going to be about neonatal abstinence syndrome, and then the next is going to be about children's integrated services and the work that we do there. I do work at the state team for children's integrated services, but I see lots of my colleagues who are out in the field in our crowd today. So I just am also hoping that you will jump in and answer questions and help me to explain some of the work that we're doing every day in the field, so that I'm not the only one talking, and because I know that we have a lot of experts here in the room. So I invite that. Please do jump in and join me as we're going through some of these slides. And we can go to the next slide, please. So today we're going to talk about the role of early childhood professionals in monitoring development and the ways in which we might see when there's an issue and then offer some early intervention when needed. We'll just discuss milestones, the ways in which we look at red flags or things that might be something of concern that would increase our ability to make an early intervention. And then we're going to identify resources and referrals. And we'll talk a little bit about, again, children's integrated services and necessary referrals that you might want to make for children in your care. And then we'll talk about longer term development outcomes, again, knowing that those really vary person to person. Next slide, please. Whoops. Oh, here it comes. All right. So we're going to talk about the developmental areas: brain development, vision, motor, speech and language, cognition, and behavior. Next slide, please. So right off the bat from birth, brain development can vary kid to kid. Some reports differences in brain development that include reduced structural connectivity within the brain observed in the first 4 to 6 weeks. So this is our brain scans of kids that young. And again, some of those resolve and some of those look pretty typical even after 4 or 6 weeks. And then in other times we see sort of persistent atypical brain scans. We also see differences in how the amygdala connects to different regions. So lots of differences again in structure that could or could not be present. Altered brain matter that persists throughout childhood, again, not a given, but in some cases is definitely seen in reduced gray matter in newborns. You can go on to the next slide. So this is a list, and I'm not going to go through all these. This is a list of some articles. This is for those of you who really want to geek out on your NAS articles around brain development. And basically, it just shows the different, these articles really go in depth into what they saw in brain scans in kids compared to sort of typically developing children or children who are not exposed. So if you're looking for some good bedtime reading, here it is. And if you're looking for some more cases specific to what you might be seeing in a particular client or family, you can go on to the next slide. So these are a bunch of vision development issues that might come up. Again, I'm not going to go through every one of them by themselves, but I do want you to be aware that there could be visual issues for kids with NAS. So it means that as you're thinking about children, caring for children, vision should be on your radar. And of course, we know that vision is so important to development for lots of different reasons and can affect even things like social and emotional development for a child. We want to have visual maturation on our radar as we're thinking about how best to serve children. And also knowing that failed vision exams could be a first step, a first doorway into providing services for our families. Being really careful if vision exams are a part of your service care area, then you might really be thinking about, could a failed vision test include a need for some more assessment around NAS or prenatal exposure. On to the next slide, please. Oh, this is just what I covered. Visual impairment, it can have an effect on children's development due to importance of interacting and exploring an environment. It can also impact social skills, language acquisition, learning, and independence skills. We can talk more about that if you have any questions. Next slide, please. So motor development. So this is our gross motor, or how kids are moving their bodies. Research shows that it's varied, that some infants don't show any motor development delays or differences, and others experience some atypical motor patterns. And we'll discuss what those look like in infancy, toddler, and young children, or young adults rather. Next slide, please. So in our infants, we may see atypical motor patterns. So that includes fidgety, little hands that are moving all the time, movement, increased occurrence of torticollis. That's something that we see a lot in children's integrated services. So that's where the neck is moved to one side and children have trouble moving to the other side, or it might just be that they just go to one side and they're not able to move their necks that way. Luckily, that's something that early intervention can really help with, and there are good outcomes predicted if we're able to catch that early. Higher incidences of atypical neurological examinations. So those are things like reactions, responsiveness, affiliation and reward, a lot of neurological things that can happen that may look a little bit different from peers. And for infants in withdrawal process, so and remembering that withdrawal doesn't happen in all children who have exposure, and then it won't always look like this, but hypertonia can lead to the back arching as the body moves into extension. So sometimes we see these kids who can't come down and they look very tight, that tight muscle tone. And then swaddling and nutritious sucking, of course, can help decrease. So like any baby, swaddling and providing that good sort of deep pressure for an infant, and then inviting some sucking for self-soothing. So next slide, please. In toddlers and kids, there are lots of different reviews, lots of different studies. I'm not going to go through all these studies, but one showing 25 kids with exposure in utero. This one basically said that the McCarthy scale was significantly lower for those children. And again, as Michelle pointed out last week to everybody, this needs to be controlled for with Medicaid. So thinking about control groups and thinking about Medicaid versus non-Medicaid patients. And I'm just seeing the chat here. Oh, never mind, that's you're just answering questions, thanks. And then we have a couple other studies, and I won't go into those, but they're in the bottom if you're interested in those, and basically significantly lower on the McCarthy scale again, which is the motor development scale. So we'll go to the next slide. So long-term, again, we don't know. Sometimes it shows that long-term motor functioning is fine in normal ranges, and then sometimes it shows that exposed groups performed lower than a control group. And some people might have some more anecdotal incidences that you want to talk about after this around motor development. I think that varies person to person, again, and kid to kid. I've seen kids who are really in the typical range, normal range, sometimes even bouncing off the walls and doing a lot of great motor development stuff, and then other kids who really are significantly struggling, and it's just so many variables that are at play there. So we'll go on to the next slide, please. So speech and language development can definitely be affected by NAS. Emerging research suggests that children with opioid exposure experience delays in speech and language. In children's integrated services, we're seeing more and more referrals. And right now, speech and language development referrals are the most that we have. So compared to all the other sort of ways that a child might be referred, speech and language is the reason that they would most often be referred to CIS right now, just in the past year or two. And again, so many factors are a part of that, but just know that it is growing and that our need for speech and language early intervention is growing as well. And that doesn't just have to do with NAS, it has to do with so many things, including COVID, masks, and children being at home and all that stuff. And then another current study that you can read about here about NAS has to do with relationship to infant feeding skills, communication, literacy. All right, next slide. Thank you. So this is a study about children, about special education children. This is elementary school children that we're talking about, that showed a significantly higher portion of children with a history of NAS diagnosed with speech and language impairment. And again, that's special education and our elementary school age kids in the study. Children with a history of NAS were significantly more likely to receive speech therapy than children without a history of NAS. What this suggests, children born with NAS can experience long-term learning challenges in childhood. More studies needed to better understand long-term effects. So like I said, it can really vary a lot. And right now research is still noticing differences, and there's more research to be done because it does vary kid to kid. Moving on, please, next. So this one is a graduate thesis. You can take it for what that's worth. Speech language pathology about communication difficulties. This was an online survey, so it was really around language disorders and sub-skills around sort of hearing and being able to comprehend, and showed that children with NAS or exposure to opioids might be behind children who did not have exposure. Next slide, please. And this is another study about speech delays and how prevalent they might be. So you can see in the NAS group and the high risk group, they had higher percentages than children without exposure. Next slide, please. So when we're talking about cognitive development, we're talking about kids and the ways in which they learn to do what they need to do, executive functioning, all the sorts of things involved with learning, growing, being able to attend and think through consequences, all that. There's emerging research suggesting that prenatal exposure can impact cognitive development. So I'm going to go through these slides pretty quickly. Again, they're studies specific to cognitive development. And what I want to say here again is that sometimes we do see cognitive delays and other times we do not, or we see delays in certain things like memory or ability to attend or attention. And those are the most prevalent, I would say, attention-related cognitive development issues with children with NAS. All right, next slide, please. So data from 13 studies of over 500 children with prenatal exposure reveal a significant difference in neurocognitive development for children with prenatal exposure. So there you go. Next slide, please. And again, this was a study done with preschool and elementary school kids, and is a meta-analysis of 13 different studies. So over 700 children with prenatal exposure and about 1,300 controls. And there was a significant difference in this study as well. So neurocognitive development, children with prenatal exposure performing less or lower than children without exposure. Next slide, please. And so this one was about assessing children 18 months to 3 years compared to health control infants. So the greatest difference in cognitive abilities was showing significant lower cognitive scores on the Bayley. And significant cognitive differences persisted at the 3-year assessment mark. Next slide, please. This one is about cognitive development for school age and young adults. And again, it was a meta-analysis of 3 studies, 152 kids, and it showed a significant difference in cognitive and neurocognitive development. And again, there are lots of variables there and a lot of differences in the lives of the children involved in the studies. So, but take it for what it's worth. Next slide, please. This one is another study comparing kids with prenatal opioid exposure to healthy controls. And exposed boys scored significantly lower on all assessments. But I will say that that's also true of boys and girls on these assessments. So I'm not sure why that's included here. Exposed girls scored lower than the control group at all assessments and did not have significant difference until the final assessment. And this study showed that boys with prenatal exposure had significant stable lower performance, whereas girls experienced increasing difficulties over time. Next slide, please. So we'll move to behavior. Existing research suggests that NAS and prenatal opioid exposure does impact behavior throughout childhood. So commonly reported behavioral difficulties in this population are inattention, difficulties with self-regulation, and impulsivity. That's what I was talking about earlier, issues with attention and ability to attend in school. And again, these are lots of reasons that children might be referred to Children's Integrated Services between 12 and 24 months of age when differences with peers really emerge. So this might be a time when in assessments with children in that age, 0 to 3, you might be looking for, if you're interviewing a family or have a child in your care, you might be looking for differences in behavior, and you might be asking some questions about what they look like compared to peers in terms of behavior. And that might be a red flag that you might need to do a referral there for some services. All right, so we'll talk a little bit more about behavior. Next slide, please. And I need to speed up a little bit because we still have Children's Integrated Services to talk about. So basically, studies show that early behavioral differences, children might experience difficulty with negative affect, decreased self-regulation. These are the kids who might cry all night, be unable to be comforted. They might have increased sensory-seeking behavior, so wanting to suck all day long, or wanting to have that wubby or that blanket close to their face to increase that ability to self-soothe. Next slide, please. In toddlers and preschool kids, we see lots of different behavioral capacities impeded. And that might mean that they have hyperactivity, they might have more tantrums. You know, this is a kid who goes from 0 to 60, has lots of issues dealing with transitions or with moments, unexpected things that happen during the day, or they might be children who are harder to calm down after an upset. Really see lots of behaviors here around just an inability to move from one thing to the next or to regulate in a typical way. Next slide, please. And in school age, this one, thank you. Mental health status of school age, it shows a history of prenatal exposure and other substances. When we use the strengths and difficulties questionnaire, children showed significantly higher differences in the subscale. So emotional problems, hyperactivity problems, again, contact or peer problems, prosocial behavior issues. So these are children who are struggling to regulate, and for that reason, of course, experiencing social and emotional upsets. Next slide, please. And this is another study that was done that examined cognitive and social emotional functioning of children with mothers receiving substance abuse treatment while pregnant. And it showed that basically children born to mothers with substance abuse treatment in their background did have more mental health problems. Yep, you can move on. Great. Longitudinal, this was another study with school age kids, and it basically showed children throughout childhood. So it assessed them both at 4.5 years of age and then 8.5 in school. So children at 8.5 had had significantly more regulatory problems reported by caregivers and teachers compared to their comparison group. You can move on to the next slide, please. All right, so let's talk a little bit about Children's Integrated Services. And again, I've got my colleagues here, so jump in if I'm not explaining something well. We basically have 4 service areas. early intervention, specialized child care, early childhood and family mental health, and strong family home visiting. On to the next slide, and we'll talk about each of those individually. Great, so this is our population. We're prenatal to 6 years of age. We get about 5,400 referrals annually and 1,500 kids served monthly. 62% of the kids that we served last year were Medicaid recipients. I can't see that last one. 50%. Oh, here we go. We can move to the next one. Oh. 50% receive early, I don't know if that's an early intervention. I think it's early intervention. So we have, early intervention is our primary service. So that's 0 to 3. It's basically special education for kids 0 to 3. So that's that Part B of the Part C of the Individuals with Disabilities Act. You can move on to the next slide. Thanks. So our early intervention population, that 50% of kids, are kids at risk of developmental delays or disabilities. And we offer lots of different services: developmental education, occupational therapy, physical health therapy, and speech and language pathology. And then we have EI as part of that Part C, IDEA Act, the Individuals with Disabilities Education Act for kids 0 to 3. So the state must ensure that kids receive services. This is federally mandated services for children 0 to 3. The funding is part of that grant. We get $2.5 million a year as the state to cover the cost of these services. And it's paid through a monthly case rate and referral service and fee for service. Next slide, please. So specialized childcare is our next sort of piece, and that is assisting families in accessing and maintaining childcare placements with qualifications. And there are grants to provide transportation for kids who are eligible. And there are SAG grants, special accommodations grants for child care programs. And this is for inclusion of children who might have a trauma background, a developmental delay, or a neurotypical profile, or neurotypical atypical profile. There we go. And might need some individual aid or assistive devices to be included in a child care setting. These are also, our specialized child cares are also where kids who are in foster care are provided child care. Next slide, please. Then we've got our home visiting programs, and I see a lot of nurses on the call with us here today. So we have a sustained home visiting program and responsive home visiting, and that means registered nurses or family support. Our sustained home visiting is registered nurses who deliver long-term structured evidence-based home visiting. And then we have our maternal and child health nurses and family support workers who provide regular home visits in response to time-limited needs. So these visits are well-being, parenting skills, social connections, and other immediate needs of a family with a child. Next slide, please. Early childhood and family mental health. It addresses an event or detects social, emotional, and behavioral mental health development needs. Often these referrals come through child cares or come through a primary doc, and they expand a young child's access to mental health services. That might look like therapy. It might also look like parent-child interactive therapy or parent-child psychotherapy. There are lots of different interventions that we might do for a child who is eligible for early childhood and family mental health. Next slide, please. So CIS integrates the early childhood system across sectors. So if you look at this little map here, we see pediatric medical home, the early child. It's basically everywhere a child is, in their home, at their medical home, and then in their early care or educational program. And CIS works across those sectors. So with all different partners, specializes in childcare with CDD and FSD. We've got our nurse home visitors who are in the home and who are doing home visits and doing Help Me, things like Strong Families Vermont or the Help Me Grow. And then we have the Ideas Part C and the Agency of Education that is really overseeing some of those education programs after a child is 3 years old, and early childhood family mental health, which is with the Department of Mental Health. Next slide, please. So it's an interdisciplinary teaming. every level. So basically we have our state team, and then we have our fiscal agent contractors. So those are the designated agencies, or those who are holding the contract with the state to provide these services to families. Then we have our regional CIS admin team that does all the referrals and all the billing and all the stuff to make sure that everybody gets paid for what they're doing, and that we're reporting to our federal grantors on what we're doing. And then we have our local CIS coordinators, who are the individuals who are working with our regional teams and making sure that referrals are streamlined and that kids are getting services in a timely manner. And finally, we have our regional intake and referral meetings. Those are meetings for all the partners who might be a part of a child's team to come together and talk about what's going on for a family. Next slide, please. This is how CIS is structured. You can see a map here of our different networks of community providers. So you can see we have 12 different districts across the state, and families and providers work together on a one plan. You've probably heard of a one plan, or you might be well versed, and maybe you write them. St. Albans and Middlebury serve under integrated family services contracts, which are held. I don't know what that says, so what that's supposed to say. It's a little bit cut off there. But somebody from St. Albans or Middlebury maybe can jump in and tell us more about that when it's time for questions. Next slide, please. So basically, this is a map of how children come into Children's Integrated Services or the Families Connection. They'll be referred to CIS. The CIS coordinator will receive that referral. By day 5, initial contact with a family will be determined to make sure that they have a plan for next steps. By day 45, there'll be an intake, a screening, assessments and evaluation, and an initial one plan meeting. So one plan will be developed with goals and outcomes. Next slide, please. And these are all the mandated timelines around how we're providing services to kids. This isn't something we made up. It is part of our federal contract. So basically, day 1, family signs a consent. Services must begin within 30 days. We have an ongoing one plan monitoring. So every 6 months, we're looking at that one plan with a family, see how we're doing on our shared goals, the goals that the family created around their kids. And a review must happen every 6 months. And then finally, we have an annual review where we're looking at goals. We're noticing when a child has met goals and when we need to tweak or change service delivery. The reason for so much monitoring is that so much happens in the life of a child 0 to 3 years old. So much growth and development happens that every 6 months, really, that child is like a whole different kid. All the parents out there will probably agree with me that this is a really important time to keep monitoring and to keep shifting the ways in which we're delivering services so that we best meet the needs of a child working toward developmental goals. Next slide, please. This is just an introduction to the one plan. Again, I think most of you are really familiar with it, and if you're not, it's the Vermont's Individualized Family Service Plan. That's something that's federally mandated so that a family really is the driver of the plan for how their child will receive services and what goals their child is working on. It's comprehensive across settings and across service delivery and providers. That means that a child's goals around speech and language, along with a child's goals around motor control or motor development and behavior, could all be a part of a one plan. It's an overview of the primary stages of CIS program. So it basically will include all those services that we just talked about. And it's a guide for conversations. So it's a place where families can really talk about strengths, resources, concerns, and priorities. It's also an accountability measure, a service grid basically for the services that we're going to deliver. And it includes family consent so that we're really explaining to families what we're going to do, making sure that they understand what we're going to do, that they've been the drivers behind the services, and that they're consenting to having those services for their child. Next slide, please. That's it.
This is Jesse. Hey, Sarah, that is the last slide.
That's it. Perfect. All right. So I wanted to save a little time, and we do have a couple minutes left, I think, if I'm right, Jesse, so that if people had questions, They could offer them now.
Absolutely. There is one in chat from Pam Cummings.
Yeah.
Can someone from Middlebury or St. Albans explain their contract when we get to questions?
Perfect. I'm just looking to see who we have from Middlebury. Don't be shy, guys.
Hi, it's Heather Simpkins in St. Albans. I'll just jump in. It just means that mental health services are rolled in as well instead of being separate.
Perfect. Thanks, Heather.
Mm-hmm.
Any other questions or any sort of comments about what we just talked about a little bit? Anything about Children's Integrated Services or NAS? There's more that I missed too if our experts on the phone want to jump in. Can anyone refer to CIS services? Great question. The answer is yes. And a family can self-refer. So now and then we do get a family that calls and says, I need help. What can I do? And that's great. We really encourage that. Any other questions? Our website, Children's Integrated Services, if you just Google Children's Integrated Services, there's a list of our regional coordinators. So depending on the area that you're looking to make a referral in, you'll see the CIS coordinators contact info there. And that's the best way to make a referral. You can call and they'll let you know next steps. Excuse me. Okay, yeah, Jesse.
So I do want to leave a little bit more time for questions, and that there was a lot of information that you shared, so people might still be processing. Yes. So thank you for that. I want to take a moment to just add that this question of connecting these children and families, or how to connect these children and families to Children's Integrated Services, is the main reason that we're doing this training series. So Vermont has a very innovative model in Children's Integrated Services. And Vermont also, by a lot of standards, has a fantastic response to children with neonatal abstinence syndrome and families that have experienced opioid exposure more generally. And we're struggling with the connection between those. And so as our center was looking at this training series when it became available, as state partners were thinking about should we do this or not, it was really this issue of how can we help these children and families that are eligible for Children's Integrated Services to get connected, for referrals to happen and for supports to start. And we do have another message in chat.
Yes, from Keneally. Thank you, Keneally, for that question. So the question is, what would you recommend for follow-up if a child qualifies for Children's Integrated Services and parents are not following through with the service? It's hard, isn't it? And I think a lot of us can jump in and offer suggestions on that. And the ultimate truth is that families are responsible for, and they're able to say no. If they don't want services for their child, they can say that. So that can be, and DCF, you might have been in a situation where you might say that's part of a case that you're building with a family around, are they able to access services that are essential to their child? But unless it's something that's mandated, it isn't something where we can say you have to have these services for your child. They get to choose. That's on the parent to choose. So this is a question specifically around, and I see we have a couple of our medical providers on here, and I am going to punt this to you guys, but the answer to this question is yes, but maybe Michelle or somebody can talk a little more, Dr. Shepard can talk a little more about this. So the question from Ben is there a safe way for a pregnant woman to continue medication-assisted treatment with buprenorphine? And the answer is yes, but I'll give it to somebody who knows more about medicine than I do.
That's a great question, Ben. The answer is they should all continue buprenorphine or methadone treatment throughout pregnancy. It is the best treatment for opioid use disorder. And it is actually dangerous for people to discontinue their medication without really close monitoring. And it's generally not recommended to stop. It's recommended to continue as it provides the best chance of remaining in recovery in that first year of life after the baby's born.
Thank you, Dr. Shepard. And Keneally, I see your next question about referrals. Are referrals for CIS tracked? Yes, they are. We keep track of every referral that comes in and every child that is referred. So if you're concerned that you might have made a referral, or if you're interested in how many referrals have been made for a child, you can be in contact. I will say that is confidential information. So unless you have permission from a family, we wouldn't be able to disclose if a referral had been made. But if you're working with a family as a DCF worker, then certainly that might be something where you have access to that information. It just depends on it. But yes, we keep track of those numbers, and those are available to families. And then Pam gave a great suggestion. Routines-based interviewing can help families in prioritizing goals for their families and just create some buy-in. So thanks for that suggestion. Any other questions or comments? Okay. Well, I'm certainly available. If you have any specific questions around CIS, I encourage you just to call me or email, and I'll put my my contact information in the chat here. Feel free to reach out. I'd love to hear from you.
Great. Thank you so much, Sarah, and thank you so much everyone for those questions. Sarah, I just got the contact information from you. Were you trying to send that to everyone, or?
Yep.
Oh, I think it just came to me. So I can copy it in a minute. That. Yes, but while you're doing that, I need to introduce our case presenter, who needs no introduction. Sara Ford is going to present a case today related to children's integrated services. So I'm going to let her take it away. And you already did the chat. I was going to do that for you. Okay, so let me get back to screen sharing. But just before I turn it over to you, I know some of you experienced this already, others haven't. So just quick intro to how the case presentations work. So Sarah's going to share a case with some background information. And the goal is for you to shift from sort of participant learner approach to your as a consultant. So listen actively to what's going on. And after she's done, the first opportunity is ask any clarifying questions. So we'll have a brief period where you can ask her questions. And then after that, we're going to break up into smaller groups. I believe we'll break up into 4 groups. And that's our opportunity for those small groups to discuss recommendations and resources related to the case. And then after all of that is shared, then we're going to summarize all of that information and give it to the case presenter. So again, a plug for any of you that are thinking about being a case presenter. You get a summary of all of the resources and recommendations that this fairly large group of your colleagues statewide can offer. So that's the framework. So right when she's done, again, the first questions are just clarifying questions, information that you would need in order to provide recommendations or resources. Then we'll do the small groups to share with that. All right. So Sara, I'll let you get started as I figure out how to share my screen again.
Great, thanks. So I am presenting for a CIS colleague and someone that I've worked with for a lot of years. She and I were able to take a good amount of time so that she could explain what's going on with the case that she's working on right now. And she really is looking for active support. So this isn't a case that's resolved. This is something that she's working on currently. So any sort of thoughts or ideas that you might have for her would be much appreciated. She wasn't able to be here herself today, but I am going to share with her anything that you have, any sort of ideas, and it is a pretty interesting case here. So I'll get started just telling you a little bit about the case. If you have really specific questions about it, I might not know the answer, but we did talk pretty extensively about what's going on. So I feel like I have a good sense. She is a mental health provider. I don't know if I put this in either, and works closely with her regional CIS team. And that referral, the referral to her was for some behavioral research. She provides behavioral support specifically for families, adoptive and foster families in her area, and then works pretty closely with the CIS team around services. So we can go to the next slide. Just make this smaller. Yes, so she's a family and mental health provider, and she offers case consultation and addresses social and emotional support needs for children 0 to 12. Next slide, please. So this was a set of this is adoptive parents, and they were referred to the provider when child care expressed concerns about the child's development in social and emotional learning at 20 months of age. Child was presenting with lagging verbal skills, high energy, low coordination, difficulty regulating and self-soothing, and trouble with age-appropriate executive functioning and following routines of the day in the child care. Birth mom relinquished parental rights voluntarily at 3 days postpartum. Child was born at 33 weeks after maintaining good contact with prenatal providers, and mom was following maintenance on buprenorphine throughout pregnancy. Next slide, please. Child spent 4 weeks in the NICU, being premature with no symptoms of withdrawal after the first 72 hours. Adoptive parents entered child's life at day 4, provided consistent care ever since, adopting at 16 months of age. Child met physical developmental milestones in gross motor and cognition on the later side of normal for the first year. But parents in child care began to notice lagging skills with peers when child entered daycare at 14 months of age. Next slide. Primary areas of concern right now, parents are concerned about autism. Child seems not to hear or notice other children, although that does look different one-on-one with an adult. Provider notices that parents are concerned about child's prenatal and birth history. So this is my colleague. The colleague is noticing that parents are concerned. They're anxious to diagnose current functioning as related to trauma of birth and adoption. And neither parent has significant experience with opioid use disorder, misuse disorder, other than adopting their child. Both are very concerned about what lagging social skills might mean for their child long term. Next slide, please. So the goals here, the provider would like to help parents to understand what NAS is and what it is not, and to empower parents to feel they can get support for themselves and their child. Barriers, these parents are doing lots of unhelpful research on their own, which is making them panic. And parents may have unrealistic expectations about what assessment and services will be available to them in their very rural community. Next slide, please. That's it. I'm happy to take questions. Or if anything was unclear.
Just to be clear, I have a question, sorry. The child is currently 20 months old now, is that right?
Mm-hmm.
Okay.
Yep.
These parents have any other kids at all, birth parents or other adopted children in the home?
Yes, they have another adopted child who's 5. And I'm seeing the question, do you have any screening information? ASQSE was done by the primary doc after this, after parents requested it because the child care had expressed concerns. So they did the ASQSE, and it did show significant concern around social emotional learning. Concerns about hearing, has there been screening for that? I don't know about hearing. I'm not sure if that's happened. And has there been an EEG done or seizure activity? No seizure activity reported. In fact, they reported like a lot of clean health, bill of clean health, and kid being very healthy in general. Although this is a child who's pandemic baby, hasn't had a lot of exposure to illness. Is the child enrolled in any programs or services currently? Nope, the child just started daycare about 6 months ago, I think she said. That makes sense. Yes, she's 20 months old, so 14 months of age, so 6 months ago or so, and that was due to COVID. So they had kept this child home, and now this child is enrolled because they were able to find a spot finally and had staffing and all that stuff. But no other services and then wondering about their underlying thoughts about children with diagnosis such as autism impacting their memory. Yes, I think all that is at play. Parents are just super really willing to have support, but they do live in a really rural area, and I think they're really worried. And it also sounds from the provider like this is a really different experience from the one that they had with their other adopted child, who is very typically developing and high functioning. Are parents connected with any support groups for foster and adoptive parents? Great question. The answer is no. They did not. They always knew that their objective was adoption, and they haven't. They have a couple of friends who have also adopted, but are not part of any formal. They didn't have a great experience fostering and adopting, and they haven't stayed connected with any groups. Although they do have a couple of friends that they get together with occasionally, although COVID again has really kept them isolated since this child came into their life. They could be connected to family network. Yeah, lots of great stuff coming in the chat. I wonder if we want to break into groups just so that we can catch some of this. Some of these questions. I'll just answer a couple of questions that I know. How's the child's sleeping history? I meant to add that sleeping is a concern for this child, and they have an erratic, sort of really difficult bedtimes, really difficult time at napping, especially at childcare, and a lot of difficulty waking up as well, very groggy and out of it and cranky. Is the child bonding with parents and siblings? Yes, great question. They have a loving relationship at home, lots of, does really well, it sounds like one-on-one with an adult, and is more responsive, more affected, and with good sort of back and forth and sort of serve and return stuff with an adult. But it needs to be one adult with the child, no other distractions. The other child doesn't need to be there, like all that for the child to do well. So then lots of suggestions, which are great. Curious about regulation and interactions before 14 months. Another good clarifying question. Because of COVID, this child stayed at home with one parent all for the entire time since they were released from the NICU. So this child has not had any previous social interaction because of COVID. So parent actually quit her job to care for this child at a time, well, both children. So, okay, I think we might be ready for our breakout rooms.